Can everyone see that okay? Sorry for the technical difficulties. Okay, perfect. So good morning. My name is Kristin Allen, and I'm the geriatric pharmacy resident at the Rocky Mountain Regional VA Medical Center. And today I'll be talking to you about my quality improvement project, which was evaluating the outcomes of pharmacist referrals among older veterans after an emergency department visit. So these are my abbreviations for today's presentation. So the objective of today's presentation are to define age-friendly emergency department care. We'll then discuss how age-friendly emergency department care works at the Veterans Health Administration. We'll discuss the importance of pharmacy involvement in the emergency department. We'll discuss Rocky Mountain Regional's Geriatric Veteran Emergency Department program specifically. We'll review the different components of the geriatric pharmacist assessment. We'll review the objective and methods of the Pharmacy Geriatric Emergency Department Program Quality Improvement Project, and then we'll discuss the conclusions and the future directions from the Quality Improvement Project. So the number of Americans over the age of 65 is projected to soar to 94.7 million by 2060. And the population of those who are specifically 85 years and older is expected to double in that same time frame. So older adults routinely receive unwanted treatment that does not align with their priorities. They miss that necessary evidence-based care. They can undergo that functional decline when mobility is not encouraged. They can experience that avoidable delirium and that cognitive decline. And then they can be harmed by those high-risk medications. So the Institute for Healthcare Improvement did launch the Age-Friendly Health Systems Initiative, and that really aimed to introduce a framework of the evidence-based practices across different clinical care settings to really improve the care and reduce the harm for our older adults. So to review the 4Ms framework specifically in an emergency department setting, we first have what matters, which includes having those goals and values of care conversations, talking about advanced directives and that life-sustaining treatment, talking about palliative care if it's appropriate in that situation, and then also discussing the durable power of attorney. And then we have medications, which will be the primary focus of today's presentation. And age-friendly medication should not interfere with what matters to our older adults. It shouldn't interfere with mobility or even mentation across those different settings of care. And so this section includes completing that medication review and management, screening for those potentially inappropriate medications, and then screening for polypharmacy as well. And then next we have mentation, which is to prevent, identify, treat, and manage dementia, depression, and delirium across all of our settings of care. And then lastly, we have mobility, which is ensuring that older adults move safely every day in order to maintain function and do what matters. And so this includes physical therapy, promoting ambulation, maintaining that physical function and preventing falls, as well as screening for any fall risks that may be present. So the age-friendly health systems at the Veterans Health Administration is led by the VHA Office of Geriatrics and Extended Care. So they do reliably incorporate those 4Ms that we just discussed into those care for older adults. And this can help address coordination across programs and initiatives. It addresses disparities in discussing health goals. It can support the 4Ms documentation, and then it also can measure those health outcomes that are associated with age-friendly care. So I did review a couple of studies that emphasize the importance of pharmacy involvement in the emergency department. But first, to give you a little bit of background, older adults are going to be at high risk of readmissions, and this is often due to issues that are related to medication management. And so pharmacists can really play a pivotal role in addressing these medication-related concerns, and this can potentially reduce the readmissions. So the first study was a retrospective single-center cohort study performed in an emergency department in Australia, and it aimed to determine if integrating that emergency medicine pharmacist into that emergency department care model reduced those unplanned hospital readmissions within 28 days. And then they wanted to identify what interventions the pharmacists were able to employ. So the inclusion criteria for this study included patients who were over the age of 65 on more than three medications, and then also patients who presented with falls, cognition changes, or reduced mobility. And then patients who were planned to discharge to home and were not being admitted into the hospital. So they did find a significant reduction in unplanned hospital readmissions among participants who did receive the pharmacist intervention compared to the controls. And a total of 107 interventions were documented, and they emphasized that medication selection recommendations. And then they also identified any adverse drug reactions or drug-drug interactions as that primary area of focus. And then over 93% of those proposed interventions were accepted and implemented by the emergency department physician. So pharmacists were involved in medication history taking, they did medication reconciliations, and they were in really optimal positions to identify and address those medication-related problems. But they also did several other interventions that I wanted to highlight. So they changed medication orders and they were able to clarify medications. They did medication selection recommendations. They participated in that discharge liaison service and those administrative issues. They helped with therapeutic duplications, overdoses, the subtherapeutic dose or duration, any adverse drug reaction or drug-drug interactions. They also did medication education and helped with deprescribing when it was appropriate. So they concluded that the inclusion of a pharmacist in the aged care service emergency team responsible for managing older patients being discharged from the emergency department was associated with a reduction in those unplanned hospital readmissions within 28 days following that discharge from the ED. And these findings suggest that that collaborative intervention between different healthcare professionals may have a positive impact on the patient-centered care. The limitations of this study were that it was a small study and the intervention was carried out in a single institution by a single pharmacist. So this may have limited the generalizability to other institutions and pharmacists. And then data was also collected focused solely on readmissions at their hospital. So they may have underestimated the readmissions if the patient were admitted somewhere else. So the second study was a prospective open-label parallel group randomized clinical trial in France that assessed the efficacy of a pharmacist-led transition of care program in reducing emergency department visits related to the same medication-related event at 6 months compared with usual care. And the inclusion criteria in this study included adult patients who were 18 years of age and older with a medication-related event when they were admitted to the ED. So they defined medication-related events as adverse drug events with and without misuse, and then medication non-adherence with unfavorable clinical evolution. So they found that the emergency department visits within 6 months for the same medication-related event were significantly lower in patients exposed to that transition of care intervention than in those receiving the usual care. And the type of interventions that their pharmacists were able to make included those therapeutic modifications, medication discontinuation, biological or clinical monitoring, therapeutic education, and then those specialized medical visits. And I also wanted to point out that in this study, the mean pharmacist time required for that medication-related event detection in the emergency department was about 60 minutes per patient. So they concluded that a targeted pharmacist-led transition of care intervention for patients presenting to the emergency department with the medication-related event did lead to a large reduction in the subsequent medication-related events related to their ED visit. And limitations of this study is it was conducted at that single university hospital that made it less generalizable. And then the availability of the integrated pharmacy services may vary across different healthcare systems, so that also made it less generalizable. And then we had the absence of a single integrated and up-to-date medical record that was shared between the hospital and the community that created a challenge for that transitions of care. And then the third study was a systematic review and meta-analysis that was performed to identify emergency department-based geriatric medication programs that are associated with a reduction in the potentially inappropriate medications and the adverse drug events. So they included randomized clinical trials or observational studies that focused on emergency department-based geriatric medication programs that do provide that emergency department clinician support to avoid those potentially inappropriate medications and then to reduce those adverse drug events. So they found that the clinical pharmacist review was not associated with a decreased hospital admission or length of stay, but they also found 2 studies that showed a 32% reduction in potentially inappropriate medications from deprescribing. They found 1 study that had the emergency department geriatrician teleconsultation that was associated with enhanced deprescribing of potentially inappropriate medications. They had 3 clinical educational intervention studies that showed a 19% reduction in potentially inappropriate prescribing, and then 2 computerized studies showed a 40% reduction in the potentially inappropriate medication ordering. So this graph really illustrates the findings of that potentially inappropriate medication deprescribing. The random effects meta-analysis showed that combined odds ratio was 0.68. So that implied that 32% reduction of those potentially inappropriate medications with that clinical pharmacist review. So they concluded that a multidisciplinary team, which included either a clinical pharmacist and or a geriatrician, was associated with improved potentially inappropriate medication deprescribing. And then they also found that the computerized clinical decision support systems, either alone or in combination with the emergency department clinician education, was associated with enhanced geriatric ordering and those prescribing practices. But limitations of this study were that it was focused on those emergency department-based interventions for older adults. So any intervention that occurred outside of the emergency department was not captured in these studies. And then we also had the exclusion of studies that were not randomized controlled trials or observational cohort studies. And then there's just a limited number of studies with data that are available for meta-analysis on this topic. So in summary, the inclusion of pharmacists in the emergency department care model can be associated with a reduction in unplanned hospital readmissions following the discharge from the ED. And then a multidisciplinary team, including the clinical pharmacists, can be associated with improved, potentially inappropriate medication deprescribing. And then the overall findings of these studies really suggest that that collaborative intervention between healthcare professionals may have a really positive impact on patient-centered care. But the current literature that's available on this topic is really limited, and many studies are based outside of the United States, as you could tell. And so that limits the generalizability to healthcare specifically here in the United States. And then the current literature also focuses on those pharmacy interventions that happened in the emergency department, and not much literature is really available highlighting pharmacy interventions post-emergency department visit. So these studies show that pharmacy needs are often high among our older adults presenting to the emergency department because of those challenges regarding the medication management. And while pharmacists can really play a crucial role in addressing these needs, a standardized approach to the geriatric emergency department pharmacy care just has not been fully developed. So these studies, again, also focus on those pharmacist interventions that are made in the emergency department. And studies showing those interventions that are made outside of the emergency department are really lacking. So the purpose of our study was to describe the geriatric pharmacy needs and evaluate that post-emergency department interventions performed by a pharmacist among our older adults presenting to the emergency department. So the goals of the Rocky Mountain Regional VA Medical Center's Geriatric Emergency Department program are to identify older veterans at risk for geriatric syndromes and unmet needs, to improve the experience for older adults who do present to the emergency department, to coordinate care from the emergency department to the right team at the right time, and then to really improve the patient-centered outcomes through evidence-based interventions, continuity of care, as well as veteran preferences. So the process for this program starts with a veteran who presents to the VA emergency department, and then an identification of seniors at risk is completed during triage if the veteran is 65 years and older. And if the veteran scores positive on this screening tool, then a geriatric veteran assessment is completed. So the geriatric veteran assessment was designed by our team, and it does include a variety of different assessments. So they look at delirium, they do a brief confusion assessment method, they look at cognitive impairment and caregiver burden. They also look into activities of daily living, they do a fall risk evaluation and a polypharmacy evaluation, and then they look into nutrition and elder abuse. And so the polypharmacy evaluation that was created by our team at the VA was the focus of the quality improvement project. So with the polypharmacy evaluation, it not only screens for polypharmacy, but we also look at any potentially inappropriate medications and adherence concerns. So veterans will screen positive if they're taking 10 or more oral medications. So when completing the polypharmacy screen, our geriatric EDRN will evaluate if they're on 10 or more oral medications, and that includes at the VA and outside of the VA, so any non-VA medications as well. And then they'll screen positive if they're prescribed any of those potentially inappropriate medications, which we'll discuss in a second. And then they'll screen positive if they've missed or forgotten to take medications 2 or more times in the past 2 weeks. And so generally, our geriatric EDRN tries to ask about adherence in an open-ended way. So how often in the past 2 weeks have you missed or forgotten to take any of your medications? Because this often reveals other barriers that the veteran may be facing that we can address during our pharmacy appointment. So I also wanted to include a case discussion on a real patient I have worked with this year. So we have DL, who is a 70-year-old female that presented to the VA emergency department and screened positive on the ISAR. And then a GeriVet assessment was then completed. She endorsed to falling twice in the past year, but denies feeling unsteady when walking. She states she has been nervous about falling ever since she fell the first time right after her blood pressure medication was increased. Her current VA medication list consists of 6 medications, so that's lisinopril, carvedilol, metformin, methocarbamol, Miralax, and Eucerin cream. And she also stated she's forgotten to take her medications 4 times in the past 2 weeks due to being very busy with her grandchildren. So with DL, would she screen positive or negative on the pharmacy evaluation, and then why? So both of those are right. So for polypharmacy, that would not make her screen positive on the evaluation because she's on less than 10 oral medications. But then she would screen positive on the potentially inappropriate medications and then the adherence concerns because she's missed her medications more than 2 times in the past 2 weeks. So we're now going to talk about the geriatric pharmacist assessment, and we'll come back to the case in a moment. So with the geriatric pharmacist assessment, if they do have that positive polypharmacy screen, then the geriatric clinical pharmacist practitioner is notified through the electronic health record. And then our geriatric EDRN will complete the assessment and will add our geriatric pharmacist to the note if a polypharmacy evaluation is positive. So that's positive for polypharmacy, adherence concerns, or those potentially inappropriate medications. And then our geriatric pharmacist then reviews the note. But if the veteran has an upcoming appointment with like their primary care team pharmacist, their home-based primary care team pharmacist, or another pharmacist that they're already following with, she'll generally just notify them of the ED visit and request for them to follow up. But with everyone else, a return to clinic is entered for a 60-minute appointment over the phone, and then our scheduler will outreach the patient to schedule that appointment where we do a medication review. Okay, so this is a really busy slide, but I wanted to show what it looks like in our electronic health record. And this is our current note template. And this medication review is pretty standard for a pharmacy review, but it also includes those specific sections to assess for potentially inappropriate medications in older adults. So I start with focusing on medication management. So that's really asking the patient, do you manage your medications or does someone help you? So that could be a caregiver, that could be a home health service, that could be a family member. I'll then readdress adherence. So ask that question, have you missed or forgotten to take your medications in the past 2 weeks? And then we'll look at any medication barriers that they may have. We specifically ask about if they have trouble opening any of the pill bottles or swallowing any of the medications. And then I review any kind of pertinent labs, any of the high-risk medications, as well as those potentially inappropriate medications on the Beers list. And then we look at medications that may have missing indications or no therapeutic benefits. And for those, we do try to offer possible safer alternatives if any kind of issue arises when we're doing these reviews. We also look at renal dosing and look at any kind of medication side effects that the patient may endorse during these visits. And then we look at duplicate drug classes and then any significant drug interactions. So when we're completing these visits, we do a full medication reconciliation, and then we also do therapeutic monitoring assessment. So if they have hypertension or diabetes, we'll assess the control just based on their labs and if they're taking their medications and things like that. But specifically on our potentially inappropriate medications, again, these refer to medications where the potential for harm can outweigh the clinical benefit, especially when that safer alternative exists. And so that's why the possible safer alternatives is in our template for our note, because we can recommend those safer alternatives if they're on any of these medications. And this is by the 2023 American Geriatric Society Beers criteria for the potentially inappropriate medication use in older adults. And these, again, identify those medications where that harm can outweigh the benefit, especially in the older adults. So the emergency department staff does not screen for every single medication on the Beers criteria. What pharmacy did is we composed a list of common potentially inappropriate medications that they may encounter that are on the VA formulary. So the different subsets that we included was our first generation antihistamines, especially our diphenhydramine, and then our antidepressants, our benzodiazepines, our Z drugs, our skeletal muscle relaxants, our sliding scale insulin, the sulfonylureas, and then our antispasmodics. So more specifically for our first generation antihistamines, these are included because they're highly anticholinergic, and then the clearance can be reduced with advanced age, and then tolerance does develop when they use them as a hypnotic. And they just increase the risk of confusion, dry mouth, constipation, or other anticholinergic effects or toxicity. And then cumulative exposure to these drugs can increase the risk of having falls, delirium, and dementia, even in younger adults. And then we have our antidepressants, which increase the risk of falls or fractures, and those are specifically for our SNRIs, our SSRIs, and our TCAs. And then they can exacerbate or cause SIADH or hyponatremia. So that would be for mirtazapine and SNRIs, SSRIs, and TCAs. And then they're highly anticholinergic, they can be sedating, and then they also can cause that orthostatic hypotension. And then next we have our benzodiazepines and our Z drugs. So they increase the risk of delirium and CNS adverse effects. And then they also can increase the risk of falls or fractures, as well as abuse, misuse, and addiction. And then our skeletal muscle relaxants are typically used to treat the musculoskeletal complaints, but they can be pretty poorly tolerated by older adults because of their anticholinergic effects, as well as their sedation and their increased risk of fractures. And then effectiveness at dosages that are tolerated by our older adults is also questionable. And then we have our sliding scale insulin, which increases the risk of hypoglycemia without improvement in hyperglycemia. And we want to avoid insulin regimens that include only those short or the rapid acting insulin that's dosed based on their current blood glucose levels without concurrent use of basal or long acting insulin, because that's just really being reactive to their blood sugar when our goal with insulin management is really to be proactive. And so this recommendation does not apply to regimens that do have that basal or that long-acting insulin on board. And then we have our sulfonylureas, and they have a higher risk of cardiovascular events, all-cause mortality, and hypoglycemia than our alternative agents. And they can increase the risk of cardiovascular death and ischemic stroke. And then among our sulfonylureas, we do have our longer-acting agents like our glyburide and our glimepiride, and these can confer a higher risk of that hypoglycemia. And then we have the antispasmodics, which are highly anticholinergic, and then they also have that uncertain effectiveness. So back to DL, which of her medications are considered potentially inappropriate medications and why? Sorry, I'm saying one. Yes, methocarbamol. So that's a potentially inappropriate medication. And again, they can be poorly tolerated in older adults just because of that anticholinergic adverse effect, the sedation, and then the increased risk of fractures. So now going into my quality improvement project for this year, it was evaluating the outcomes of pharmacist referrals among older veterans after the emergency department visit. So the objective was to assess how our current polypharmacy process was implemented in our geriatric emergency department at the VA by evaluating which veterans get screened, why they screen positive, and then what different recommendations or interventions were made from these medication reviews that were completed by our geriatric pharmacist following their ED visit. So this was a retrospective quality improvement study that reviewed medical records to describe a sample of older veterans, 65 years of age and older, seen by a geriatric pharmacist between September 1st of 2024 through September 30th of 2025. And the veterans were included if they screened positive on that in-emergency department pharmacy screen that evaluated for polypharmacy, adherence concerns, and the potentially inappropriate medications. So they were then referred to and completed a post-emergency department visit with our geriatric clinical pharmacist practitioner, and outcomes included reason for the pharmacy consult, time from the emergency department visit to the pharmacy visit, and then the clinical pharmacist practitioner's recommendations and interventions. And data was analyzed using descriptive statistics. I also wanted to note that during this time period, we were adapting and piloting an updated polypharmacy screen in the emergency department. So our old tool only had 3 questions and it did not include medication-specific information. So we really wanted to expand on the ability of this tool to be tracked through our geriatric ED dashboard, but we also wanted to include that drug-specific information. So during this time frame, we were working with our health informatics team to pilot this new tool, and the geriatric ED nurse was testing the new tool for feasibility in the emergency department. So in order to capture every time our new tool was used, we did have to use that larger time period. And our geriatric EDRN was also using both tools during this time frame. So the number of results that we got were limited. But one of the main points of this project was to assess how our new tool was performing for feasibility in those geriatric ED reviews. So we did get 50 total pharmacy referrals in that time frame. And out of these 50 referrals, 7 of the veterans were screened in the emergency department, but they weren't referred. 1 veteran was screened in the emergency department and referred, but a pharmacy visit did not occur after the referral. And then 6 veterans were included in the data pool, but they were not applicable to the quality improvement project because they were either negative on the pharmacy screen and it just accidentally pulled, or the consult was just deferred to their primary care team. So after excluding these consults, we ended up with 36 veterans who had a positive pharmacy screen in the emergency department, and then they were referred to our geriatric pharmacist for follow-up. So the sample was primarily male. So we had 32 veterans, or 89% of the sample being male, and then 4 veterans, or 11% of the sample being female. And our mean age was around 77. So the lowest age was 65, and our highest age was 101. And this is pretty consistent for our VA population in Colorado. And then the average time from that emergency department visit to when pharmacy was able to follow up was around 11 days. So the most common referral to the geriatric pharmacist, which was included in 40% of 23 of our referrals, was for polypharmacy. And again, polypharmacy in our project was defined as 10 or more oral medications on a veteran's active medication list, again, including VA and non-VA medications. And this was followed by any adherence concerns, which was included in 37% or 21 of the referrals. And adherence concerns, again, was defined as missing or forgetting to take medications 2 or more times in the past 2 weeks. And then we had potentially inappropriate medications that was included in 16% or 9 of the referrals. And again, these aren't all the potentially inappropriate medications on the Beers list. These are the specific ones that we identified. So our first generation antihistamines, our antidepressants, benzodiazepines, Z-drugs, skeletal muscle relaxants, sliding scale insulin, sulfonylureas, and then our antispasmodics. And when I was doing these reviews, I did look at the specific potentially inappropriate medications that were identified. So those included like hydroxyzine, amitriptyline, cyclobenzaprine, methocarbamol, sliding scale insulin, and glimepiride. So you can see a lot of those were our muscle relaxants. And then 7% or 4 veterans were referred for other reasons. So this could include discrepancy between the veteran's medication list and the medication list in their chart. So this can often happen at the VA, as some of our veterans do seek care outside of the VA, so in the community, and the charts just don't talk to each other. So if there's any discrepancies when going over the medications, they will refer them to us. And then this also includes medication concerns, any medication barriers identified during the screening. We had 1 patient that was having trouble reading the prescription label, so he was referred. And this can include medication questions as well. So if they're talking to the geriatric EDRN and they have a question about a medication and opt to speak to a pharmacist, this would warrant a referral. So the most common pharmacy recommendation did include to discuss alignment of medications and goals of care. And this was followed by lab recommendations and recommendations to discontinue potentially inappropriate medications. And so the potentially inappropriate medications that were recommended to be discontinued included 2 muscle relaxers and then glipizide. But when we were talking to the patient, a lot of these potentially inappropriate medications, especially those muscle relaxers, were either as needed or the veteran said they just seldomly use them. So it wasn't deemed that the risk outweighed the benefit. So we ultimately didn't make a recommendation to discontinue them. But in addition to those 3 recommendations, I also wanted to highlight the other recommendations that were made during these appointments. So that included to discontinue supplements, suggesting an alternative medication to a potentially inappropriate medication, changing the formulation of a medication, changing the day supply or how often they have to take a medication in a day just to improve adherence. updating the prescription to reflect what the veteran's doing at home, alerting the primary care pharmacist if they just needed assistance with disease state management, discontinuing a medication based on labs or side effects, but also talking with the patient about food products that can cause certain side effects like diarrhea, decreasing the dose of a discontinued medication until follow-up with the primary care provider, decreasing the dose of a medication due to side effects as well. And then the most frequent pharmacy intervention was performing a medication reconciliation. And this was followed by medication counseling, care coordination, and changing to easy open caps. And so not all of our veterans did get a medication reconciliation, and this was because some veterans declined a full med rec, especially if they were confident, that their list that they got in the ED matched their list at home. And then some of them just received a partial medication reconciliation, especially when they had a specific question on one of their medications. But other interventions that were made by the geriatric pharmacist included discontinuing medications that the veteran was no longer taking, care coordination with a healthcare specialist. We ordered a lot of alarming pill boxes for our veterans, refilling medications, care coordination with the primary care pharmacist, providing information about upcoming appointments. We ordered the medication take-back envelopes for medications that they were no longer taking. We placed a lot of medications on hold per the veteran's request. We don't have automatic refills at the VA, so a lot of medications are just refilled when a provider's in the chart, and sometimes the patient may not need the medication yet, so they can request for us to put them on park or hold. We did partial medication reconciliations. We ordered glucose tablets and lactase from the pharmacy. And then we could request an expedited fill of a veteran's medication from the VA. A lot of the medications come from a mail order pharmacy that I believe is in Arizona, so it can take some time for the patient's medication to get to them, but we can request for it to be filled locally where it would get to them faster, so we did that for several veterans. We can discontinue potentially inappropriate medications, decrease the dose of a medication due to side effects. We counseled on our formulary changes at the VA. We sent medication directions to the veteran. And then we also provided information about how to update a mailing address in their chart, how to refill medications by phone, and then how to get a pill box if they wanted one in the future. And then just updating information in the health record as well as entering adverse drug reactions. So as you can see, this really highlights the importance of a pharmacist in caring for our geriatric patients after the emergency department visit, just because of the vast sections of interventions and recommendations that we were able to make during these phone calls. And then all pharmacy interventions and recommendations were addressed for the majority of veterans at 86%. And this is consistent with that first study that we discussed, where 93% of the proposed interventions were accepted and implemented by the physician. So these results show that older adults that present to the emergency department have pharmacy needs that can be addressed by those post-emergency department pharmacist interventions. And models of care are really needed to promote emergency department identification of pharmacy needs and then referral to pharmacists to increase access to care and improve overall medication management for our older adults. Limitations of this project did include that it was a small sample size, and then we were testing that pilot, so we were testing our new template, and that's why the sample size was smaller. And then the sample mainly consisted of older white males, which again is consistent with our VA population here in Colorado. And then the sample was conducted at the VA, which is an integrated healthcare system, so this may limit the generalizability to our non-VA facilities. So for future directions, we're working on data tracking and adding additional health codes on the template so we don't have to manually review each veteran who completes the geriatric assessment. So with those health codes, when we're pulling data, they will automatically pull data and feed it into our dashboard versus us having to manually go through each patient that we've seen. And then we're also including a consult within the template to order a pill box for our veterans. So this will allow the pill box to be ordered in the emergency department versus later when they speak to the geriatric pharmacist. I would oftentimes be talking to veterans and I noticed that they wanted a pill box, but they had said they had already ordered one from like Amazon. So this could be something that's provided through the VA. So we wanted to go ahead and include it in this initial template when they're in the emergency department. And then we also added non-selective COX-2 NSAIDs under potentially inappropriate medications. This was previously left off, and this is a medication class that's considered potentially inappropriate. And it also gives us an opportunity for an intervention or recommendation. So just talking with our veterans about as needed use or decreasing the use if possible, or if they do need to use it every day, potentially adding some gastroprotection like a PPI. And then we're also going to include a section in the template to track which veterans are receiving anticoagulants, antiplatelets, and opioid medications. And at the VA, the anticoagulation clinic does follow these patients pretty closely. And then our chronic pain and wellness clinic and our primary care providers will follow patients who are on opioid medications. So these are not patients who would be actionable for pharmacy follow-up, but we really wanted to include it in the template to gather data for our dashboard. So just to have more metrics. So in summary, by following up with these patients after they are out of the emergency department, we are really able to address any needs that they may have and answer questions on a variety of topics as seen by those recommendations and interventions that we were able to make. This allows the patient to be out of what can be a stressful environment in the emergency department. And although we did not track the hospital readmissions, this current model of care really enhances the quality of care that we can provide to our patients by not only focusing on those potentially inappropriate medications, but also being able to address other needs and concerns that they may have after their emergency department visit. But future studies are going to be needed on determining whether an in-ED or a post-ED model of care is most effective for intervening on our older adults. And these are my references. Thank you so much for having me.
Thank you, Dr. Allen. While others are thinking of their questions, I had two, and actually one mimics a question I saw online, which is about supplements. I was curious what those two supplements were that you recommended discontinuing. And I think the question online was, how do you approach supplements?
That's a great question. I'm not sure exactly what the two were that I recommended to discontinue, but when talking with these patients, I always address supplements as first asking the patient why they're taking the supplement. And because oftentimes I see, they might have seen something on Facebook, like an ad or something that says a certain supplement has benefit for a certain disease state. I often run a drug interaction with the supplement and their other medication because I feel like that's a great way to address just approaching it from like a potential harm or interacting with their other medications. And then if there's no drug interactions, I'll often approach it from a standpoint of there's not much literature that supports the supplement and helping with that disease state. And so it may just be adding to your pill burden and not actually helping. And so that's often how I would address supplements with veterans.
I'll ask another question, Zach. I love that this is happening at VA, and I think the VA is a great place for this to occur. I'm curious about, because we have really nice electronic medical records, I'm curious if we can do some sort of retrospective analysis and follow since the initiation of this program, and follow the long-term or maybe midterm outcomes of individuals who undergo medication reconciliation with an ED pharmacist versus those who did not before this type of program existed. Because I suspect that we can probably get some really good data about what are the long-term outcomes of intervening in the way that you are.
Yeah, absolutely. And I think that's why we are working on metrics and pulling data and coming up with a dashboard to help track these interventions that these reviews are when they're done in the emergency department.
Thank you for your presentation. I
Thank
was
you.
curious, it's somewhat similar to the supplement question, but you mentioned that there's a nutrition screening when patients come in. To what degree do you consider drug nutrient interactions, or what degree do you work with clinical dietitians to ensure these drugs aren't adversely interacting with typical dietary patterns?
That's a great question. I don't think currently, at least from a pharmacy standpoint, that we do drug nutrition interactions, but that could be something that could be a potential intervention in the future. Now, in specifically for the nutrition screening, I don't know very much about that because that's done in the emergency department, but pharmacy does not currently look at nutrition.
Having gone through a didactic program in dietetics myself, we had to take a very stringent medical nutrition therapy, and there was such a heavy section on drug nutrient interactions. So it was always emphasized that if you were to become a clinical dietitian,
Yeah.
to work hand in hand with the pharmacist to ensure that the drugs that the pharmacist is giving are working effectively, but also they're not getting nutrient malabsorption as a result of a drug they're taking. So
Yeah, that's
if it's not happening, maybe it's worth it.
absolutely.
Thank you for sharing your project and your expertise. I think like a lot of those PIMs are like slam dunk PIMs, you know, where you're like, yeah, we need to evaluate this. The one that's harder for me, and I do like a fall prevention clinic, is like the SSRI, SNRI discussion. I'm wondering like, what have you learned? Like you've seen so many patients and talked to them about this. What have you learned in that discussion when you're not like the PCP? About discussing like discontinuing or reducing dose of SSRIs, SNRIs?
So generally during these pharmacy evaluations, I'm more so asked if they're having any side effects. So we'll ask, have you experienced orthostatic hypotension, but of course in layman's terms to the patient, and assess if they have fallen recently. And this might more so be a potential recommendation to their provider to open that conversation the next time they see them. So in terms of evaluating the potentially inappropriate medications, it's more so focused on making sure they're not having those side effects. And then if they are, that's where we can make the recommendation to their primary care team. We try not to, in lack of a better sense, like rock the boat too much during these appointments, just because we are cold calling them. So we oftentimes have not spoken to these patients before. So when we're doing these phone calls, we're really just assessing, like, are they safe? Do they have any concerns about any of their medications? And then if something like that were to be brought up, that would be a great recommendation to their primary care provider. And oftentimes the primary care providers are really keen on reading our notes, and then they'll follow up with the patient on those concerns.
Kristin, thank you so much. I know so many of our veterans have care providers who are managing meds. How did you handle that in the QI?
Yeah, so with the care providers, we would just coordinate with them. So I oftentimes message them on Teams or just put them on the note and just highlighted my specific concern that came up during the appointment. And then when I was doing this retrospective review, I would look to see if whatever we brought up was addressed. And oftentimes
I'm referring to their loved one who's caring for them. Sorry, that kind of care provider.
Okay, yes. So those, oftentimes they were on the phone call, and if they weren't, that was of course a question that was brought up, and if they help manage the medications or if someone helps them. We often would request if they had someone helping manage the medications to be there on the phone call, because they might know just a little bit more about the medication management, any barriers that they're facing, or if they had any questions. So just asking for them to be on a phone call. I know sometimes I offered to call them back if it was a better time where their care provider could be there. So just really working with both the patient and whoever their caregiver was to see if we could coordinate a time to really have that in-depth conversation.
And it sounds like you had an hour for each appointment. Did it take an hour most of the time?
Oftentimes it did not. The times that it really did take the whole time is when they had multiple questions or concerns, or with the polypharmacy if they were on many different medications. I did speak to several patients who were hospitalized and they just got out of the hospital. So oftentimes with those appointments as well, we would take a little bit more time talking about any changes that happened when they were hospitalized, or just addressing any questions that they had about upcoming appointments and things like that.
And do you think it's going to be sustainable now that the QI portion is done?
I think so. I think we are working on some improvements in our template and our data tracking and working, what works best and what doesn't and going from there. So I think so. It's a really great project.
I'm going to expand on the supplement question from earlier, which is an online question from Lisa Price. And she asked, do you count the supplements in the 10 meds? Where do they fit in the deprescribe? And I think she's asking because there's very common things like multivitamins and probiotics, and that could push people above the 10 medications. And do you find patients more or less resistant to stop supplements?
That's a great question. So they are counted in the 10 medications if they're oral. So the only medications we've excluded were topicals, because oftentimes patients can be on several different topicals, and those weren't really identifying patients that we could intervene on. So they are included if they're an oral medication on the veterans medication list. And when approaching this with veterans, if they opt to stay on it, as long as there's not any, I'm not concerned about any like drug-drug interactions or coming from a safety perspective. I do not try to push it, but I do try to provide them education. And I always leave it open-ended, being like, if you would like to reduce your pill burden in the future, there's just lack of efficacy that this supplement helps with this disease state. I would love to talk to you more about this in the future, or you can discuss this with your primary care provider. And I oftentimes find that approaching it from that perspective is really well received because they don't feel pressured, but I'm still giving them that information.
Any last questions? Thank you very much, Dr. Price.
Thank you. Okay.
Thanks.